Hello, I am Dr. Sathish, specialist pediatrician working in eye care clinic under Emirates Health Group in YSC Center. Today's topic is bedwetting or nocturnal enuresis. Bedwetting is a common problem causing distress to parents. Urinary incontinence is passing urine at inappropriate time and place in a child above 5 years of age. It can be continuous or intermittent. Intermittent further classified into daytime and nighttime. Nighttime incontinence or nocturnal enuresis are two types. Primary, wherein the child is never attained dry night from infancy. Secondary, where there is reappearance after 6 months of dryness. Monosymptomatic means no associated daytime symptoms, and non-monosymptomatic as associated daytime symptoms. Monosymptomatic is the simple bedwetting we discussed today. It is defined as repeated urination into bed or clothes occurring twice per week or more in at least 3 consecutive months in a child of 5 years old and not due to either as a drug side effect or medical condition. Two physical functions prevent bedwetting. The first is antidiuretic hormone that reduces urine production at night. The second is the child's ability to wake up when the bladder is full. Children usually achieve nighttime dryness by developing one or both of these abilities. There appear to be some hereditary factors in how and when the child develops these. The causes can be defective sleep arousal, loss of nocturnal rise in antidiuretic hormone, nocturnal detrusor overactivity, functional reduction in bladder capacity, and genetics. If both parents had this in their childhood, there is 70% chance of child getting this. If only one parent had this, 40% chances are for the child getting this. Normally, 10 to 15% of children will have bedwetting till 6 years of age. 1 to 2% graduate every year, and still 2 to 3% remain bedwetting at the age of 15 to 16 years. First, rule out diabetes by finding out whether the child is losing weight or child has excessive thirst. Simple urine test will rule out sugar and urinary tract infections. Constipation, fecal incontinence, any development delay, any family history of same should be ruled out. Check whether it is difficult to arouse the child from the sleep. So, assess the development, monitor the BP, neurological examination, genital and per rectal examination also should be done. Bladder diary and voiding chart are important to see how often and how much child pass daily. Enuresis in a previously dry child, daytime incontinence, weak stream, straining, excessive thirst, behavioral problems in child are pointers to serious conditions. Most children grow out of this by time. Reassurance only is needed. No treatment before 5 years of age. Family involvement is very important in the treatment. Treat constipation and snoring first. Do psychiatric consultation if there is any behavioral problems. Do not punish and cause guilt feeling in the child. Use incentive when the child is in control. Reduce fluid in the evening and night time. Empty bladder at bedtime. Nighttime lifting before the anticipated time of bedwetting also help. If these measures are not helping, you can introduce enuresis or desmopressin. Alarms are of two types, wired and wireless. Use till 14 consecutive dry nights are achieved or for 3 months. Desmopressin has a risk of hyponatremia and water intoxication if not combined with water restriction. Take one tablet 1 hour before sleep. Restrict fluid from the evening. Stop treatment if no effect in 2 weeks' time. Treatment on occasions like traveling or camping also is an option. Combination of alarm and desmopressin also can be tried. Anticholinergic like oxybutynin with or without desmo is the next line. Third line is imipramine with or without desmopressin. Only good words and praises, no punishment and penalty in the treatment. Then you can get rid of bedwetting. For treatment and expert advice, you can approach any of our branch or call 800 iCare 800 42273. Thank you very much.